Dr. Carey Roth Bayer, Associate Professor in the Departments of Community Health and Preventive Medicine and Medical Education at Morehouse School of Medicine. And I'm joined today by Dr. David Malebranche, Primary Care Physician at the University of Pennsylvania Student Health Services, and Dr. Laura Dickey, Assistant Professor in the Department of Psychology and Behavioral Sciences at Louisiana Tech University. Thank you for joining us today.
Thank you.
Glad to be here.
I'm wondering if you can tell us about some sociocultural factors that contribute to health disparities for lesbian, gay, bisexual, and transgender persons.
Go ahead.
Well, I mean, there's a slew of them, so I think we kind of look at the whole template of intersectional forces that can happen. So, I mean, you start with things like geography, where you live in the country, to things like poverty. That can be a starting point, and then you look at different cultural factors, issues of race, ethnicity. When you think about gender identity, sexual orientation, you're thinking about LGBTQ populations. These things don't exist in a vacuum. So when you conceptualize it, you have to realize that people are growing up in their cultures, in their different settings. And so behaviors, whether it be sexual behaviors, how things are expressed, formations of masculinity, femininity, how they intersect and how they ebb and flow over time has a lot to do with the conditioning in which someone grows.
I think another piece of that is socioeconomic factors, especially with people who are transgender, gender nonconforming. I see study after study of trans people who have advanced degrees, master's and doctoral level degrees, but yet consistently they're making less than $10,000 a year. So many trans people are either unemployed or underemployed based on the training and experience that they have, and that especially seems to affect trans men who come to their position as men having had a history of being a woman, and as we know, women are typically underemployed or at least underpaid in the work that they do. 75 cents on the dollar, I think, is the latest that we've heard around that. And so trans men are especially affected by that because that privilege, if you will, of being male hasn't necessarily followed them in terms of the training that they had leading into their employment.
You talked a little bit about history. What role does childhood experiences play? What role does stigma, either interpersonal or structural, play in the health disparity picture?
I think the whole ways that people are acculturated, the expectations that are put on them in terms of how they're supposed to behave, especially with trans people. Gender non-conforming boys have a much more difficult growing up experience than gender non-conforming girls do. I think boys who are labeled as sissies or femmes or whatever the terminology is that you use, it's much less acceptable for them to express a broader range of gender than it is for girls who have a tomboy expression. That doesn't mean that girls don't get bullied as a result of that, but I don't think they're bullied as severely as gender non-conforming boys are.
Yeah, I would definitely agree with that. That's a great point. And I think the other thing that you think about are sometimes issues of, within families and communities, issues of sexual abuse and violence happens. There have been a slew of studies, particularly with men who have sex with men or gay identified men. And often it does depend on the gender performance. If they tend to perform in a more traditionally masculine way that's accepted by society versus feminine, some of the cis men may actually, if they perform in a more feminine manner, people may target them. And so you'll see young boys getting abused, and that doesn't quite get the privilege that it does, or get the attention that it does if you're a young cis woman. And so it's an interesting dynamic because when you look at childhood sexual abuse, it can lead to substance abuse later on, risky sexual behaviors, an increased likelihood of being exposed to HIV. Those things can happen. Another thing I was going to mention along with childhood sexual abuse is issues of religiosity, and these all tend to intersect. And so depending, and particularly within Black Latino communities where A lot of religiosity has been utilized and incorporated over time to deal with racial trauma, racial discrimination, things like that. Some of these things actually work on a different level when we're looking at LGBT manifestations within these communities. So if someone has very staunch Christian or Muslim beliefs or something like that that tells them that someone who isn't in a heteronormative context is somehow a sinner or somehow lesser than or somehow abnormal, that can really play a part on the psyche and the experiences of a young LGBT youth coming up.
So we've heard a little bit, you've talked a little bit about religion, you've talked a little bit about kind of poverty or socioeconomic status. What other factors around identity can play into this picture as well?
I think especially racial and ethnic minority people are adversely affected in those ways for some of the very same reasons Dr. Malebranche has already talked about, the religious perspective around that. It tends to be less acceptable as a racial and ethnic minority to come out as LGBT than it is for white people. Again, I'm not saying that white people have it all figured out, because they certainly don't. But I think that within communities and within families, people tend to be even less accepting. And for a lot of LGBTQ youth, too many of them are being kicked out of their homes, even today, by their parents. I think I saw just a week ago a study that over half of the homeless youth, and I think it was in Southern California, are LGBTQ identified. And that's certainly strongly overrepresented in terms of the people who are living on the streets. And the problems with those kids is often they end up engaging in survival economies, whether it's drugs or sex, in order just to be able to keep a roof of some semblance over their head. And you talk about the consequences of that, becoming addicted to drugs at such a young age or being involved in street economies around sex. You're just opening yourselves up to so many other types of risks and challenges that the average child who's living under mom and dad's roof are never going to experience.
Right. Yeah, I agree with Dr. Dickey. I think, and particularly when you look at the intersection of race, sexism, with all these kind of different things, you can see how all these play out and can adversely affect a lot of our LGBT youth. And particularly when we talk about race, I think it's more not so much the conception of race, but the experience of racism that kind of traumatizes folks. And I think within a lot of Black and Latino families, they're already facing a lot of adversity for being Black and or Latino. And so I remember doing some focus groups years ago with a group of Black men who have sex with men. We did it in New York and in Atlanta and in upstate New York as well. And a lot of the guys, we were saying, well, you know, when you go into a medical practitioner's office, do you tell them that you have sex with other men? And a lot of the guys were saying that, you know, well, when I go into a doctor's office, they're already looking at me as a Black male. And they have a certain set of stereotypes that they're sizing me up as. They think I do drugs. They think I'm more violent. They think I'm uneducated, all these other things. So why would I open myself up to another avenue of discrimination? And so when you start to consider those intersecting forces, and how they come into play, and then how sexuality and disclosure and openness about your sexuality or your sexual orientation comes into play, you can see why some people can choose not to disclose in certain scenarios and maybe disclose as another. And then when you look at traditional paradigms of this binary kind of coming in or coming out or staying in the closet, doesn't quite fit as neatly, and it's a little more nuanced with that. And it's true, as Dr. Dickey was saying, it's not that European Americans or white Americans are less homophobic or less tolerant of non-heterosexual, gender expressions or sexual orientations. I think it's just that there's different ways that it's manifested, different ways that it's expressed, and different pressures that people of color may be feeling before they even get to the point. And it speaks to a lot about white privilege, which intersects with male privilege, which intersects with these other kinds of things. So it gets very, very complicated. So it makes all of our jobs a lot more difficult when we're trying to address the healthcare needs of our youth. It's hard.
So you've touched on the youth aspect. Do the social and behavioral determinants of health change across the lifespan for LGBT populations?
I think the age level that we're beginning to focus on more are older adults, and the ways in which they're having to closet themselves again after years of having been out when they seek medical care. They go to a nursing home or some other type of institutional care, and they're not allowed to, their partner isn't able to be with them because the institution that they're in is not going to be supportive of that. Trans people who have not had lower genital surgery are not getting the kind of care that they deserve because they aren't treating the organ systems that are present. They have a certain expectation of what this person looks like and what they're going to see when all their clothes come off, but yet it's something different. I mean, my biggest fear in life is that at some point I need emergency medical care, and I'm not cognizant enough to be able to say, hey folks, look, this is what to expect when all my clothes come flying off. And who's then going to advocate for me if I'm not conscious to be able to do that? So what are the ways that we can continue to train people to not, that gay panic defense doesn't just happen when we're talking about intimate care, it also happens among medical providers. And how can I can't be an advocate for myself if I'm not conscious, and who's going to be there to do that?
Yeah, and I think another aspect of it is you're saying, like, over the time continuum, like we talk a lot about LGBT youth, which is kind of an added pressure to deal with your sexual orientation, your gender identity, and how you're going to express or disclose that. In addition to being an adolescent going into emerging adulthood, it just adds different layers of difficulty. But I think as you see over time, and it's not to say that over time, you know, people automatically become more comfortable with who they are. And some people, you're right, may actually go back and regress depending on what situational context they're in, or if they're in a situation where they say, you know, I really can't disclose because I'll fear that I'll lose my benefits, or I'm fearing that my medical provider or someone else is going to discriminate against me. But I think over time, if you see where people may get better jobs and their socioeconomic status may improve, they get health care insurance, and you see some of the advances that are done with issues of gay marriage, and with issues of providers being a little bit more culturally competent. And I can't express enough like how big, I was almost in tears when the Time magazine cover came out with Laverne Cox on the cover, because I don't think I'd ever thought in my life I would see that cover on Time magazine, and the exposure that it gets and how that ripples through, where it becomes an issue where I think over time and over decades, and some of us, we may not live to see where it gets to this point, but it's going to get to a point where everything is just going to be more normalized, where things will be accepted, and no one will bat an eye when someone says, I'm trans, or I'm gay, or I'm a lesbian, or this is my partner. And you won't even have to make that formal announcement anymore. And won't that be a good world? But as it stands now, I think we have to be aligned, whether we're researchers or practitioners, kind of being able to follow our LGBT community at each step of their generational advancement. So when they become adults, what are the priorities and needs that they have during that time period, as they're finding jobs, as they're hustling, as they're settling down into relationships and considering marriage and that stability, as they're having kids. Those kind of things start to come to play. And then as they reach older age, exactly what you said, like, where's my family? Where's my support? Is the community around? There's a lot of research talking about some of the older gay and lesbian men in particular, some of whom were HIV positive, some of whom were HIV negative. If they were negative or positive, lost a lot of their friends and extended family when they were younger. And now they're facing 50s and 60s, being older and not having that support. And if they don't have their biological family support, it gets a lot more complicated. So I think there's a lot to be done, but I think the wise thing, as Dr. Dickey said, is to really look at this almost like a generational thing, and look at, as you get a little bit older, there are certain priorities and certain things in life that we're going to have to address that are a little bit more nuanced, a little bit more complex for, you know, people in LGBT communities.
There are also some challenges with trans folks depending on when they came out. Somebody who transitioned 30 years ago transitioned under a time and an era where the goal was, post-transition, you would be heterosexual, you would avail yourselves of all of the surgical options and medical options that were available, And on the other side, you would be stealth. Nobody would know about your trans history. That's not the case today. Today, people stop along that gender continuum in a wide variety of places. Maybe they want chest surgery, but no hormones. Maybe they want low hormones and no surgery. There's all kinds of different combinations. It's, instead of it being, you have to get this full menu approach to what you do and do all of those things and be heterosexual on the other side, because God forbid we create more gays and lesbians. Like, that was not acceptable. Now we've got a more a la carte approach to how people are choosing to transition. And the idea that someone could be in a third gender space and not buy into this binary idea of who they are as a gendered person. The challenge is, in the medical profession, very much saying that, oh, no, you have to do these things in this order. And there are places in the country where that's still very much the case. There are also places in the country where people are using a more informed consent approach to how they handle treatment and allowing that you could have chest surgery first and then maybe somewhere down the road decide you want to start hormones. That's fine. Right. We have different ways that we look at that. But if somebody came out of that 30 years ago model, their idea of what it means to be trans, they're going to push that aside and not lead with that in any way, shape, or form. Where today, you see a lot of the younger people who are coming out exploring their gender and exploring their sexuality in ways that weren't even possible 20, 30 years ago.
You touched a little bit on geography. Does geography have a role in this picture? Does it help or hurt in the health disparity
Depends
picture?
on the geography. I live in northern Louisiana, and it is not helpful. Where you're in where? Philly?
I'm in Philadelphia, but I was in Atlanta for about a decade, 11 years. And so when you're in, we talked about religiosity before. If you're in the Bible Belt, I mean, you cannot ignore that context and how that influences families, communities, and the way LGBT folks exist. And being in Philadelphia, it's a much different context than being in the Northeast and kind of the way people are used to the fluidity of gender identity, sexual orientation, and expression. So people don't really freak out as much, and there's not so much condemnation. I mean, obviously there's some with every community that you're going to see, but I think particularly in the Southeast you're going to see that. But it's interesting because even if you look at the Southeast with disparities of income levels, racial disparities, health disparities on all different levels, the Southeast seems to have a lock on adverse outcomes, educational quality. It all seems to be in the Southeast. So I don't know whether religiosity is directly tied to that or it's a confluence of factors with that, but you know, to me, obviously, it's a no-brainer that if you're growing up in the Southeast, you're going to have a more difficult time if you're of some kind of gender non-conforming experience.
You also look at the issues around health insurance. Mm-hmm. I work for a major university, a state school, and not only does my health insurance policy say that all sex transformation procedures are excluded, it says that even if those are determined to be medically necessary. Dr. Malebranche is at a place where not only do the students have health insurance coverage, it covers transition-related care. Mm-hmm. I mean, yes, there are caps on that, but those are two very different, and my guess is that even if I was in New Orleans, that would still be the case with my health insurance, because that's about the state that I live in. As opposed to the fact that I'm in a rural environment.
Yeah, those are like the final frontiers. I think once you get providers on board, and we're not just talking about physicians, we're obviously talking about nurse practitioners, physician assistants, all get involved in the care. And the more we see mid-level providers getting involved, the more we realize that we have to include everyone, because these issues of cultural competency. And what's interesting is that a lot of times when we do cultural competency, we tend to segregate LGBT health from kind of the race, ethnicity part of it. And I think one of the things where we can move forward in medical fields is actually integrating that a little bit more. Because something that's interesting is that in cultural competency, when we're talking about race and ethnicity, they often talk about you don't want to stereotype somebody. So you don't want to say something like, well, because you're from this Asian country, or because you're Latino American, or because you're African American or Caribbean American, this is how you're going to act. And as a provider, you should address this accordingly. Instead, it's kind of like, listen to where your patient is coming from. Hear what your patient's experiences are. Listen to who they say has influenced them, what their experiences are, and how they conceptualize health in particular. And I think the same approach needs to be taken with LGBT health, because there's a whole menu of gender expressions, identities, orientations, labels, attractions that fall the gamut. And so as providers, we don't need to look at somebody in a binary or even any kind of other, compartmentalized way where we're saying, okay, look, you're fitting in this box, you're fitting in this box. We need to kind of open our ears more and say, okay, tell me how you identify, tell me about your life experiences, and tell me how you conceptualize health. And also realize that that may be fluid over time. I've had patients who have come in and defined themselves as agendered, or queer, or asexual, and then as the months and years go by, they'll say, well, you know what, I feel like I identify more as a woman, or I feel like I identify more as a man. And especially when you're looking at adolescent and emerging adults, when they're kind of experimenting and kind of figuring themselves out and who they are on a whole different level, we have to allow them to kind of do that while providing care. So I think it's one of those things of being able to listen and then being able to target our care approach towards that.
So you both have had the experience of kind of living and working throughout a lot of the United States and with these populations. What would you say are some of the health risk factors for lesbian, gay, bisexual, transgender populations?
That's done. Is it sure? I would say probably mental health are probably like the top 3 or 4, because I do think when people stereotypically look at LGBTQ populations, they'll say, there's an adverse or a racial, or not racial disparity, but a disparity as far as drinking, drug use, HIV, and sexually transmitted infections. But if you look at all those outcomes, those health outcomes, and the behaviors that may drive them, one of the common threads through them is mental health. And what are we thinking about when we think about mental health? We think about whether someone may be depressed. They may have poor coping skills with the stressors that they have in their life. They may not have any social support, social capital, cultural capital that can help them handle some of the pressures of either coming into their own as far as their gender identity or sexual identity is. And so as a result, they go to other mechanisms, or they may eat too much, or they may drink too much, or they may resort to drugs, or may resort to having sexual relations with someone that could give them or expose them to an STI. So it tends to be one of those things where I think traditionally we think of health risk factors or health risk behaviors or outcomes that are disproportionately impacting LGBTQ folks. But I think stepping back and looking at the mental health of LGBTQ populations, it's going to branch out and overlap into everything from physical health, spiritual health, so on and so forth.
I think one of the biggest challenges that trans people especially face, but I know this is true for lesbian, gay, and bisexual people as well, is finding providers that they feel safe with. And that's more than just basic cultural competence. It's for a lesbian who goes to a provider year after year after year who continues to ask, are you using birth control methods? Well, if I'm only having sex with a woman, do I have any risk of pregnancy? Probably not. And so just having those really basic understanding of who your patients are, that you're able to see them as a person, not as okay, who's up next? And I get that medicine it's a field where we're turning clients around and patients around very quickly. But how long does it take to remember, oh, this is this person, and I need to treat them with the respect and dignity that they deserve. For trans people, having providers who will treat the organ systems that are present. I'm a trans man. I will never need a prostate exam. And to have someone do a rectal exam and declare that my prostate is fine is like, really? where exactly did you find that prostate? Because I didn't come with one of those. At the same time, if I have not had a complete hysterectomy, I still need to have a pelvic exam.
Right.
And how can I find a provider that's going to provide that care in a way that's sensitive to the fact that maybe I or other trans men who feel a little bit disconnected from that part of our bodies don't always feel safe with having people do those exams in ways that aren't responsive to the needs that we specifically have around that.
I think what Dr. Dickey just said is so important because it takes the onus away from focusing on health risk behaviors, which is very individual, and kind of blaming the victim, to kind of stretching it out and looking, well, what are these systems that we're existing in? And so what are our healthcare systems? What are these provider-patient interactions that we're having? And how are these influencing our experiences in healthcare? And how can we improve upon that? And I think the importance of having a provider, just as it is with anybody, is 100 times more important with our LGBTQ populations, because to have that trust factor, to know that you're not being judged, to know that someone is going to call you by your proper pronoun or your proper name, and to know that someone is not afraid to just touch you, or to look below the waist or lift up your shirt to look at things. To know that you have a provider that's comfortable doing that is a hugely intimate thing, and I think fosters a lot of trust, which again leads to increased adherence, increased acceptance of healthcare recommendations, immunizations, those kind of things kind of flow, but it all starts with the provider-patient interaction. So if you have something there, even within systems or institutions that could be crumbling or not have all the resources, you'll see patients that will follow a provider wherever they go, because you realize that you're not going to always get that same experience, and that when you have a good provider, you should stay with them.
You both have talked on the complexities of social and behavioral determinants of health. If we could create the utopia, and you've given some suggestions about that trusting relationship, what might that look like to help overcome these health disparities for these populations?
It starts to me in such really basic places. What do our forms look like? When I go into a doctor's office and they ask me to fill out all this information about myself, because every office has it, whether I'm going to see a podiatrist, an internal medicine person, an orthopedist, I always have to fill out this health history. And how are people responding to that? When I walk up and do that and say that I've had a hysterectomy, how then do the providers respond? When I'm asked to fill out information about my gender, am I forced into two choices? Or what are my options when they ask about marital status or relationship status? And what complicates that when we get into electronic medical records is oftentimes those are coded in a way that you don't get those options. And then what happens when somebody tries to push through my insurance a procedure that's only allowed to happen with female-bodied people? So there are all kinds of ways that just in the really basic, how am I introduced to this medical provider, that send up these red flags that say, I am not coming back here for all the money in the world. If this is the only person I can access care with, guess what? I'm not accessing care.
Right. And the onus, I think, is on starting with the providers to make the change within the systems. Because if we notice that there are little issues like that with the intake form and kind of how it's conceptualized, whether it be electronic medical records or whether they're doing it old school, writing down, or if we're noticing that with the insurance company, if I have a trans woman who has a prostate and they're having urinary symptoms and I order a PSA and the lab sends it back and says, this is a woman listed on this, why are you ordering a PSA, but they haven't seen the patient, that you have to kind of bypass those things in order to get things done. And so I think starting with the providers noticing those things, whatever institutions we work in, and starting to do those things on a larger level. And it will have to take involvement in policy with regards to the insurance companies and how they conceptualize things. And those are always going to be hard, long changes that take a while to get moving. But I think starting with the providers helps out a lot.
So you've shared a lot of information with us today. Is there anything we missed in this social determinants of health, behavioral determinants of health picture for lesbian, gay, bisexual, transgender populations that you wanted to touch on?
You were talking about this earlier when we were talking offline about the resilience piece, and I want you to go ahead and lead with that.
I will.
Because I don't want to steal your thunder.
No, I appreciate that. No, I think one of the things that always bothers me when we talk about racial disparities or LGBT disparities in health is that we always talk about the doom and gloom. So if we're talking about HIV, as you know, we always talk about, well, what puts people at risk for HIV? What puts people at risk for depression? I think if we start to conceptualize our research framework and focus more on the resiliency aspect of it, so in the case of HIV, if there are people who are remaining HIV negative, how did they do that? Did they do it through behavioral change? Was it a relationship issue? Was it just frequent testing? Was it PrEP? Like, what was it that they did to maintain that? The similar to being, look at LGBTQ populations and say, well, okay, how do you maintain like adequate coping skills that don't lead you down a path where you're overindulging in sex, food, gambling, alcohol or drugs, those kind of things? How do you manage that? And what outlets do you use? And how can we package that up and provide an intervention for that? Or how can we as health institutions and clinics, how can we actually support you with that? What would that conceptualization be? Would that be something that you would be involved in? Was it something that we could both jointly work on? Is it something that we need to do some research on? But I think when we talk about disparities and particularly LGBT health, and we're talking about what we need to do as providers, I think going from a deficits model to more of an assets model is going to be tremendously beneficial.
So taking that shift into health and wellness instead of disease, disaster, and dysfunction.
And crisis, right. You know.
And I think we need to look at that resilience on three levels. We need to look at how the individual is doing that and how they're engaging in coping strategies. We need to look at the community aspect. Not only what's happening within their families, but what's happening around the people that they work and live with. And then institutionally, what can we do to foster that process? And that can start, again, with really basic levels. What kinds of restrooms are available to people? Are there restrooms that where people feel safe? If I'm, as a provider, going to suggest that somebody get more exercise, and the kind of exercise that they're most likely to engage in is maybe, say, swimming, which always requires a shower after and typically before you get in the pool, how safe is a trans person going to feel if they're forced to use a restroom that has gang showers where they have to shower in front of everybody else, and maybe their body doesn't match with the other people that they're around? Or can we provide them a facility that gives them the privacy that they deserve so that they can do that in a way that they feel respected and dignified?
I think you just reminded me of something. I think some of these little privileges that a lot of people take for granted, they get flipped on end when you're talking about trans LGBT folks. Like some of the privileges that people think a heterosexual couple can walk down the street and just hold hands and not worry about, you know, whether they're going to have somebody scream something at them or be violent towards them. I was with a gentleman not too long ago, and we were walking on the boardwalk in Atlantic City, and we were both thinking about holding hands, and then we just weren't sure. It was so crowded. And I was thinking to myself, those are little privileges, and going to the restroom that has the little icon that you know, you fit in that cis category, like, okay, I fit in this gender male category, this gender female category. And what's encouraging to me is that I was at a panel discussion yesterday for the Kaiser Family Foundation, and at the beginning, and it was all 25, and I don't think there were any trans men or women there. It was LGBTQ youth that were working in HIV. And the moderator at the beginning said, we have agendered restrooms, so we want you to know just you can use any one you want. And I remember thinking, that was the first time I'd ever heard that at the beginning of a conference. And it gives me hope that it's moving slow, but I think as it's going in, as it's infiltrating into public health, medical communities, it'll hopefully become the norm where we'll know that even though there's maybe 1, 2, or 3 people in the room that could be made uncomfortable by this, that's 1 or 2, 3 people that we don't want to be uncomfortable. And so if we can create a context where everyone will be comfortable in who they are, their bodies, and not feel ashamed or think that they're going to experience some kind of stigma just from simply wanting to go to the bathroom, which is a basic human need that you have to go to the bathroom. So that'll be a better thing. But I think I get encouraged by seeing those kind of small steps taken.
Well, thank you so much for sharing your time and your expertise with us today.